All right, after we've done our antibody identification testing, a lot of times compatibility testing comes next, which includes the cross-match. So what does this include? An accurate patient ID, proper sample collection and handling, a review of the patient's blood bank records and history, if we have those available. We don't always have those available. A careful ABO and RH determination and other testing of donor units, a careful ABO and RH determination and antibody screen of the recipient, and cross-matching the recipient sample with the donor unit. Um, for the donor units, when they come from, say, the blood connection, which this is why ABOs are so important, we type them at least twice. Sometimes more than that if they've never had any donation history beforehand. And then what will happen is when the units are fully labeled to say, yes, this is an O positive, for instance, when it comes to the facility it's going to, they are rechecked again just to make sure, because again, we don't want to mess up the blood type. Compatibility testing can also include antigen negative units. So if the patient has an antibody, units that are negative for the corresponding antigen must be given. These must be serologically cross-matched through AHG. Just kind of like our last example from our antibody identification, that patient had an anti-big K. We want to make sure that we grab some donor units, test them for big K, and we have to also cross-match them through the AHG phase, which would be just like testing a cell from the panel. The patient is going to be monitored before, during, and after the transfusion. Cross-matching is routinely performed only with products that contain donor RBCs. We have two types of cross-matches, the major and the minor. The major is very much used today, day in and day out. They don't do a whole lot of the minor anymore. So what is a major cross-match? Major cross-match is the patient's plasma, or the place that has potential antibodies, and the donor RBCs, or the place that has potential antigen binding sites for these potential antibodies. So patient plasma, donor RBCs. A hemolysis or agglutination at any step indicates a positive reaction and is interpreted as incompatible. Again, major cross matches are routinely performed. For a minor cross match, we flipped it. We have donor plasma from an attached segment and recipient RBCs. These are not routinely performed. They used to be performed when giving whole blood. Now all donors have antibody screens performed, rendering a minor cross match obsolete. They actually very recently have started to give whole blood a little bit more, and we'll discuss that a little bit more when we're talking about components. But because the antibody screens are performed and because we titer the whole blood, and again we'll talk about that in components, they don't really do the minor cross matches anymore. Little history of the cross match. Prior to 1907, most transfusions were direct transfusions, and it's exactly what you think. It went from one person to another person. Hooked up one that went out, the other one that went in. Not a lot of pre-transfusion testing was performed. In 1907, the first in vitro cross-match was attempted using a lengthy room temperature incubation. So in vitro meaning like in the lab or in a tube testing. A few drops of serum and red cells were mixed on a slide and observed for agglutination before transfusion. So during World War I, ABO identical blood was transfused without a cross-match. Blood was given slowly at first, and the patient was watched for reactions. So it was one of those wait and see. If we had reactions, it was quickly stopped. The minor cross-match was made optional by the AABB in the 1960s and then made unnecessary in 1976. Wiener, which we talked about his nomenclature, suggested the use of tubes instead of slides in the 1940s. In the 1980s, the immediate spin cross-match was used if there was no history of any antibodies and there was no current detectable antibodies. That's what's going to be the basis for immediate spin cross-match. You have the patient has no history of an antibody and has no current antibodies. Let's say, back to our example again, patient has a history of an anti-K. Even if the anti-K is not currently detectable because they have a history of an anti-K, we cannot do an immediate spin cross-match. And then in the 90s, the electronic cross-match was introduced. It's like basically like a computer checking to make sure the ABOs were compatible. So why do we test a cross-match? Why do we see what's going on in the blood before we're going to give it? It could potentially prevent life-threatening or uncomfortable transfusions. If we can see it in vitro, most of the time what happens in vitro is going to mimic what happens in vivo. Not all the time, though. It's going to maximize the in vivo survival of the transfused red cells, and it's going to double check for ABO errors. Remember, ABO binds complement, which can cause maximum damage in minimum time. And that's what it does. You know, we're going to see those ABO incompatibilities and a big incompatible reaction if we have incompatible ABOs. It can be a second means for antibody detection. Um, we can also detect, again, in the cross-match is where we may see the low-frequency antigens or antibody to low-frequency antigens. When we give a unit of red cells, one not on unit of red cells should increase the hemoglobin by 1 gram per deciliter and the hematocrit by 3%. You will definitely see this again. So the cross-match is not infallible. Even if we do have successful compatibility, it has its limitations. So if we have a compatible negative reaction in vitro or in tube, it's not going to prevent viral transmission. So blood donation centers like the one I work at definitely screen for these viruses, but it's not 100% guaranteed. That's in blood bank. Nothing's ever 100%. Nothing's ever 0%. Just a cross match is not going to prevent allergic reactions. The patient also may have clinical causes of decreased red blood cell survival. That's my puppy. The disease state they may have, even if you have a compatible unit in a cross match, they could destroy those transfused red cells just like kind of they're transfusing their own red cells. You may have undetectable antibodies. So this basically says you did an antibody detection test, nothing came up positive, everything looks good. You're looking great. You transfuse units, and then all of a sudden we have something called a delayed transfusion reaction because the current titer of the antibody was too low to detect them, but when it's exposed to it again, that titer increases significantly. So, originally the antibody was undetectable. You also may have other non-threatening symptoms such as hives, rash, fever, or chills that you're not going to just limit, or excuse me, you're not going to completely get rid of just having a compatible cross-match. So in a nutshell, the cross-match steps is to obtain a recipient blood sample. So we got to get the blood from the patient. We're going to compare that with the previous records. Make sure everything looks good if we have the previous records. We're going to repeat the ABO testing of the donor blood just to make sure that unit is labeled exactly what it says. Then we're going to do the cross-matching. We do have standards and regulations governing the cross-match as how we should do the cross-match based on their previous records, current testing. Then we're going to tag, inspect, and issue the blood products. Let's go into a little bit more detail about some of these. So for the recipient blood sample, a properly collected and labeled with accurate patient identification. 2 exclamation points. There's no way around this. Has to be properly collected, so we have to have the right color top tube, and it has to be labeled accurately. Doesn't matter how stat the sample is. If we do not have a properly collected or accurately labeled patient tube, we can't work with it. It's a little bit easier in a hospital to get that recollected, but working at an off-site place as a reference lab, I may have someone that needs blood before the end of the day, a hospital that's 3 hours away, and if you send me tubes and, for example, a tube labeled with 2 patient names, there's no way for me to get around that. I've got to toss those tubes, and you got to send me some more tubes. So for the top, EDTA plasma is preferred, or ethylene diamine tetraacetic acid. You can use a plain red top tube. This is going to be your serum tube instead of plasma. Usually it's purple tops or pink tops, sometimes white tops. The sample is good for cross-match for 3 days or 72 hours in most cases. Exceptions can be made if a patient is not recently transfused or if they're pregnant. So it's kind of a protocol, facility-based to figure out what they're going to do if it goes beyond 72 hours. Again, sample must not be hemolyzed, and the sample must not be diluted with IV fluids, as we could miss potential significant antibodies. Labeling requirements are set by accreditation agencies to determine how it should be labeled. The patient must be positively ID'd by comparing the requisition to the label to the ID band attached to the patient. And you guys learn all this in phlebotomy. The patient should state their name without prompting, or a caregiver may do that for them if they cannot state their name without prompting. A blood bank ID can be used as an additional identifier. Never pre-label tubes, and always label in the presence of the patient. But you guys know this from doing phlebotomy. little more on the recipient sample. The label must feature two independent identifiers, or also called two unique identifiers. We can have the first and last name of the recipient, that's one identifier, and a unique ID number. That could be a date of birth, a medical record number, or a blood bank number. The label must also need to have a date of collection, the ID of the phlebotomist, an initial signature ID number. The label must be legible and indelible. The information on the label must match the request. If blood products are being ordered, requests must include the type of blood product and the ordering physician. So with comparison with previous records, the AABB standards require the comparison of results and current blood typing with ABO-RH typing performed in the past 12 months. All previous records must be consulted for typing anomalies, clinically significant antibodies, transfusion reactions, and special transfusion requirements. So when we're repeating testing of the donor blood, the transfusion facility must confirm the ABO labeling of all donor blood. We definitely do. The RH type must be confirmed if the unit is labeled RH negative. So why don't we do this RH positive? Well, we want to make sure that we don't have someone could potentially form an anti-D if we're giving a potential weak D positive to a patient. RH positive is positive, and it won't matter if an RH negative unit is mislabeled as an RH positive unit, because it's going to go to an RH positive person, not an RH negative person, and potentially make an anti-D. Records of repeat testing must be kept for a number of years. If a discrepancy occurs, the unit will be quarantined and returned to the donor center for investigation. This does happen a little more times than you would think. Sometimes a weak subgroup of a blood type would come out, and upon immediate testing, let's say a weak subgroup of A that we'll cover in a further lecture, may not type as A. It may type like an O. So when that's going to happen, the discrepancy is there. It's going to get sent back to us and dealt with it from there. So for the actual procedures of doing a cross-match, so we have the abbreviated or immediate spin cross-match. It may be used for recipients with, again, no evidence of present or past clinically significant antibodies. You take 2 drops of the recipient plasma, just like doing a screen, 1 drop of a 3 to 5% red blood cell suspension, just like you're doing a screen. We're going to mix it in the test tube and centrifuge, and then check it under an agglutination viewer for agglutination. The immediate spin cross-match ensures there is no ABO incompatibility. It will not ensure that the blood is compatible at all phases, which is why the antibody screen is important. So immediate spin cross-match checks for ABO incompatibility. For an antiglobulin phase cross-match, if a patient has demonstrated a current clinically significant antibody or has a history of one, antigen-negative units must be cross-matched using the AHG procedure or phase. Again, same thing as before. 2 drops of patient plasma, 1 drop of that 3 to 5 cell RBC suspension, mix. We're going to incubate using the same potentiator that is used in the antibody screen. So if you've used LIST, you're going to use LIST, PEG, albumin. We're also going to take this one through the AHG phase, just like in a screen. For the electronic or computer cross-match, also you'll see in them as called EXMs or flexible cross-matches, the computer makes the final check of ABO compatibility between the unit and the donor instead of immediate spin. The electronic cross-match can be used if the patient has no past or current clinically significant antibodies. We have 2 identical ABO interpretations have been made on the recipient. These can be made between past and current samples, and the computer system has been validated by the FDA and the user. So you can't just use an electronic cross-match on any old thing. It's got to be a FDA validated computer system. So for standards and regulations, the AABB, CAP, the TJC, and the FDA regulates these cross-matches. The cross-match must be performed from a segment originally attached to the blood product bag, not originally. The only exception to this, if we have an emergency released uncross-matched unit, and that is signed by a doctor that we know without a shadow of a doubt that it is uncross-matched. The cross-match must check ABO compatibility and shall include an antiglobulin test if a past or present clinically significant antibody is present. So, a lot of information on this one for the tagging, inspecting, and issuing of blood products. A cross-match tag is attached to each unit after compatibility testing is complete. The tag needs to have the patient's full name, ID number, the name of the product, the donor number, the expiration date, the ABO and RH of the unit, the interpretation of the cross-match, and the ID of the person doing the testing, or the tech code. A physician's order must be on file for a transfusion to occur. Again, it's the reason it's controlled by the FDA because it's considered a drug, and there'll be a prescription for it. A person requesting the unit must provide the ID of the intended recipient. That ID is checked against the cross-match tag. The cross-match tag is checked against the unit label before issue, and again by 2 nurses before transfusion. Got to have both nurses there. The expiration date must be checked. The unit is visually inspected for discoloration, clots, or any other abnormalities. The checks are documented along with the name of the persons issuing the unit and the person transporting the unit to the patient area. A segment is retained and detached from the bag for further testing if indicated. You will definitely see this information again. As far as the real life thing, since a lot of our blood is sent 2 places, we will always keep a segment in case there is any type of transfusion reaction. We can have a segment of blood to test a pre-transfusion and post-transfusion sample with, and that's why we keep those segments. So here's kind of, let me draw on this, a label so we can see some things going on with the unit. So again, we have the blood type up here, we have the day it expires. It's kind of a little obscured over here, but it says what the product is, what it's suspended in, and we're looking specifically for the cross-match label up here. Medical record number and name, the patient blood type, the unit number, which again needs to come over here and match this unit number right here. The component is red cells, which is what we have. It is compatible. This one has even the volume of the unit on it. The product type, the expiration, and then the cross-match expiration, which should be 72 hours in most cases. So again, we need to do a date and time of issue, and the unit's final disposition are also documented. So what happened to the unit? Did it get transfused? Did it get sent back? What's going on with it? Part of the cross-match tag is placed on the patient chart after transfusion. During transfusion, the patient's vital signs and clinical condition must be monitored by the transfusionist. We want to make sure they're not having any sort of transfusion reaction, be it hemolytic or not. Unmonitored refrigerators should never be used to store blood. We need to return the blood to the blood bank for storage if transfusion is delayed. That's a big deal because you don't know if it's not monitored. Is it out of temp? Has it ever been out of temp? Based on all the inspection, the guidelines and procedures and policies, blood has to be stored in a monitored refrigerator. You can reissue blood from blood bank, and it's permitted if the unit has not been spiked, meaning it's not been open to air, open system, and the unit has not exceeded temperature limitations for the product that we'll learn about. So incompatible cross matches, just something to kind of touch on here is the level we're operating at MLT and registry. Don't talk a whole lot about incompatible cross matches in a real world situation. Sometimes you will have a product that will not be incompatible that we will transfuse to someone because, based on their clinical state, they're going to be hemolyzing the red cells of that donor unit just like their own cells. So with a lot of these incompatible cross matches, especially from people that have, warm autoantibodies, we're going to say transfusion is not recommended unless it's absolutely necessary because it may not do a whole lot of good. It may do more harm than good. But with an incompatible cross match, you're not making that decision by itself. We're going to get a doctor's release for it to say there's a terminology a lot of people use, and it's called least incompatible. Well, being least incompatible is like being a little bit pregnant. Either you're pregnant or you're not. Some people like the terminology it's serologically compatible, meaning that the clinically significant things that the person has going on with them is a match for the other unit of blood. So besides the person having some sort of medical issue causing these incompatibilities, we're not going to give them additional problems going on with it. But just a little bit about the incompatible cross match, and some people really don't want to give it when you may never find a compatible unit. But again, you're not going to be doing this willy-nilly. You're not going to say, oh well, I can't find a compatible unit, we're just going to give them an incompatible one. It definitely does not work that way. So for emergency release situations, what happens in emergency? We want to give them type O RBCs, and AB plasma upon physician request. Again, got to have that physician request to go along with it. Until the ABO and RH of the recipient has been tested on a current sample. Keep in mind that even in emergencies, the specimen must be collected and labeled properly. Emergencies do not stop something from being collected and labeled properly. You cannot give blood based on history alone, and a specimen should be collected ASAP. So depending on the facility you're at and depending on their guidelines, sometimes depending on the patient, are these O positive or O negatives, and how they're going to give them. But again, we can't switch it to the patient's blood type until we get a current test on the current sample. If the patient's history shows clinically significant antibodies and time allows, units should be screened for corresponding antigens. If the antibody screen is positive, all units already issued and future units given should be cross-matched through AHG phase. So that's basically showing us that, like, if they've given them 3 units already and we know that 2 of the 3 are incompatible, we may have a bad time coming, just to let us know. A physician must sign a release prior to issuing of uncross-matched blood. The said release record must be kept by the blood bank, so we have to show that someone signed it to say, yes, this is okay to go. The units that were issued uncross-matched should be clearly labeled. When uncross-matched units are issued, segments from each unit are kept for potential further testing if needed. So massive transfusion protocols. Sometimes go along with emergencies, sometimes not, sometimes they're on their own thing. So a massive transfusion is a total volume exchange of blood within 24 hours. Usually it's type O. It's going to be between 10 to 12 units for a male and 8 to 10 units for female. The patient's pre-transfusion sample no longer represents the blood in the body. Now the sample after a massive transfusion that you're going to take is pretty much going to be whatever blood you've transfused them. So before switching the patient to their own blood type, a new sample is needed to see if passively acquired anti-A, anti-B, or anti-AB is still in the circulation, especially if they've given them, plasma components, whole blood, and all that stuff that have these anti-A and B in them. So for cross-matching autologous blood, so you can do autologous donations or self-donations. Usually autologous units do not need to be cross-matched. Type and screen is still performed, and procedures should be in place to ensure that the patient receives their own blood before any other units. So no, also talking about a neonatal cross-match. Remember, we're talking about neonates up to 4 months old because after that, they produce their own antibodies. Excuse me. Any antibodies detected before that 4-month range are going to be the maternal antibodies. So initially, neonatal testing must include a forward ABO and RH and an antibody screen on the neonate or the mother. If an antibody is present, any blood given to the infant must be negative for the corresponding antigen. Units for neonates are often aliquoted. A new cross-match is not needed unless a new unit is used or the child reaches 4 months of age. These get quite interesting when hospitals have policies that conflict each other. So again, right, like regular rules, if an antibody is present, we want to give antigen negative blood cells to it. But there are sometimes that they say all neonatal units must be O negative, and there are sometimes that mothers make antibodies because they're not O negative, the baby's not O negative, and they're going to have antibodies in there that you're not going to find very often in an O negative. Sometimes these are a 1 in a 10,000, 1 in a 50,000 that you'll find it. So sometimes you have to kind of get them to go against policy to have realistic goals in place. We also have non-RBC products. So what testing is required? An ABO must be performed on the current admission. For frozen plasma, we're not doing a cross-match. For platelet concentrates, we're not doing a cross-match. For a cryo, we're not doing a cross-match. For platelet pheresis, we're only doing a cross-match if the unit contains greater than 2 ml of RBCs. Most donor centers ensure less than 2 mLs of RBC for this reason, and they do controls and QC on it to make sure we maintain less than that 2 milliliters of red blood cells. So if we're needing blood, patient has a positive antibody screen, we've identified an antibody or antibodies. How do we determine how many units need to be screened to get the number they want? So if a patient has, a couple antibodies and doctor needs 4 units of blood, how many am I going to have to look through to find what I'm looking for? So the calculation for determining the number of units to screen when searching for antigen-negative blood is based upon the negative frequency of the antigen and the number of units needed for the transfusion. So a lot of times when we're getting these numbers, you have to make sure that we're looking at the positive or negative frequency of the blood. So the equation is the number of units needed is divided by the negative frequency of the antigen. That's going to get us the number of units we need to screen. So if we have multiple specificities present, we're going to multiply the negative frequencies together. The frequencies are always able to be referenced in a table. You will see this again, and there's like a 90% chance you're going to see it on the registry. They love to ask this question because it has so much real life potential in it, and I use this a good bit. But again, you got to make sure you're looking at the negative antigen frequency because those registry questions like to be complex from times for what may seem like a very straightforward question. They may give you the positive frequencies, but you need to know you're looking at the negative frequency of the antigens in question, which it's the number of units divided by that number. So let's look at an example. So if your patient has an anti-Duffy A, an anti-JKA, and an anti-K, how many units do you need to screen to find 2 units? So the negative antigen frequency of a Duffy A is roughly 34%. For a JKA, it's 23%, and for a K, it's 91%. So we're going to take the 2 units they're looking for, divide them by 0.34 times 0.23 times 0.91, and that's going to give us 28 units. And sometimes you do have to screen 28 units. Sometimes you may not have 28 units to screen in your facility. Depending on where you are and how you are is when you give us a call at the Blood Connection and say, I need units that are K, JKA, and Duffy A negative. Because you may not have physical time to screen these units. You may have a couple more patients to work on. So when you're in the blood donation center and you are the provider, this is when I go, well, it's going to take me 28 units. We had an antigen order just this past week, or multiple antigen orders. It was kind of crazy. For the same phenotype or the same number of bloods, it was a little C, a big E, a big K, a Duffy A, a JKB, and an S. And we did those, the frequency, 100 so units for how many units they needed, and we had to screen. And it at that time it actually came up about right. Sometimes these frequencies, aren't always 100% exact. That 28 units, you may find it in 20. It may take you, 38 units. But again, for being tested and for the registry, it's the number of units you need divided by the negative antigen frequencies. All right. See you guys on the next one.